Hmm? It's 134. Good afternoon, good evening, and good morning, everyone, and welcome to this third webinar in the series hosted by the IAS. And today's focus is on test, COVID-19 and HIV testing updates. And we're thrilled to have a terrific panel for you today. My name is Dr. Lucy Stackpole-Moore, and I'm the Director of HIV Programs and Advocacy with the International AIDS Society. And our aim for this whole series is to provide an opportunity for discussion on the pandemic, COVID-19, and have a deeper look at some of the issues that affect and impact people living with HIV. We're also aiming to connect and celebrate the contribution of IAS members around the world and in the global response, and also in strong leadership roles and very localized responses, both to COVID-19 and to maintaining attention to HIV within this difficult time. And that's IAS members spanning across the whole spectrum of science, policy, clinical service provision, community mobilization, and many other areas as well. So thank you very much for joining us today. Before I hand over to the esteemed panelists and our moderator for today, I'd just like to run through a couple of housekeeping reminders for everyone. Please note that due to the large number of attendees, everyone is muted. If you would like to share a question for one of the panelists, you'll see at the bottom of your screen something that says Q&A. Please click on that and put any questions for the panelists in that box. We have saved a good amount of time at the end of the webinar to respond to as many questions as possible. If you go into that space, Q&A, you'll also see there's a little plus symbol across. And if you see that someone else has asked you a question, please just click on the plus and that will help us prioritize the most pressing issues and questions for the discussion today. We won't be able to get to all of them, and please do keep your questions focused on testing. On the IAS website, there is a portal that includes the information from the previous webinars in the series and also other information that can also be a great source of information to respond to your questions. And you can also send follow-up questions by email to the email address, which is coronavirus, hang on, I've got to make sure I get it correct. The email address is coronaquestions@iasociety.org, and that email address is monitored at all times, and then the response to those questions will be featured on the portal, the COVID-19 portal for the IAS. So without further ado, I'd like to welcome you to today's webinar, and my special thanks to Professor Adiba Kamarulzaman, who is the President-elect of the International AIDS Society, and she's also the Dean of the Faculty of Medicine at the University of Malaya and Adjunct Associate Professor at Yale University, and Adjunct Professor at Tulane University in the United States of America. Thanks so much for joining us today, Adiba, and I'll hand over to you to moderate the session. It seems that we might be having some challenges with the sound for Adiba. So in the meantime, while she's just reconnecting.
Okay, I think, can you hear me now?
There we go, great. Thanks so much.
Okay, okay, great. So once again, good morning, good afternoon, and good evening, everyone. And thank you so much for joining us. I can see at the bottom of the screen that we have more than 360 people who've signed on for this terrific, hopefully what will be a terrific session this evening with our speakers, Dr. Lara Voshnov from WHO, Dr. Rachel Badgley, also from WHO, Dr. Cassandra Kelly-Cirino from FIND, Dr. Jerome Kim, who has pre-recorded his presentation, and Dr. Benson Yeo from Singapore. As we've got a really packed agenda to get through this, it's evening time for me, so pardon me if I keep saying evening. We'll kick off with Dr. Lara Voshnov, who will be presenting on WHO updates on COVID-19 testing. Dr. Voshnov?
Great. Thank you so much for the invitation to speak during this very important webinar series. Today, we thought it would be useful to touch a little bit on the diagnostic considerations for COVID-19. You may normally know me as the diagnostics advisor in the HIV, hepatitis, and STI department here at the WHO, but I've recently been seconded to the health emergencies team to support in the COVID-19 response. I'll give a relatively high-level overview of some of the key considerations we've been thinking about over the last few weeks, rather than focus in the limited time on too much of the epidemiology and what's happening in countries. So if you move to the next slide, one of the first things that we're really thinking about right now is who to test and what are the specific considerations, the cases when we might be considering this. Of course, we want to ensure that we slow or stop transmission. We want to make sure we're identifying cases, particularly those who are sickest, who need, in particular, specific care to try and get better. And then I know a number of different countries right now are starting to think about how we can lift some of the economic and population restrictions that many of us are facing. But of course, there are a number of countries that are in different phases of the epidemic. We have about 4 different phases that we think about, but one thing we want to consider within there, and it's much more nuanced and detailed. Hopefully the global surveillance document that I have listed here can provide you with a little bit more of the information, is a way to think about the epidemic for each country, but also to consider these different phases, these different potential clusters within a country. And so multiple different epidemics, different phases could be happening at one time. And of course, although we recommend that all suspected cases be tested for COVID, given some of the limitations that we currently have in terms of access to testing and potentially limited resources, we have suggested some prioritization of patients who should be tested first. And effectively, those are key populations who are at highest risk of developing severe disease or death. If additional testing is possible to open up to those severe enough for admission, if further resources are possible, all people with symptoms, regardless as to severity, close contacts, and then of course, potentially all contacts. And this will be somewhat nuanced and important to think about in each country, again, depending on your phase, depending on the setting. If we move to the next slide, of course, it's important to think about how you test. What are the right sample types? And we have quite a bit of guidance to try and support those different considerations in country, as well as how you're able to take those samples, ship them in order to get testing. There are a number of different current sample types, specimen types that are recommended and suggested for COVID testing. But it's important to note when you're thinking about testing that we really want to make sure that all of the sample types are validated by the supplier, the test you might use, and that it's indicated as an intended use by the supplier. This will allow countries and healthcare workers, laboratorians to ensure that the test result that you're providing is as accurate as possible. However, there are a number of research considerations that we're really starting to think about in terms of specimen types. As you can imagine, a number of these are not very appealing to do for a number of patients. And so whether we can have less invasive sample types used, potentially easier sample types, maybe self-collection can potentially be considered. But for a number of those, we need a fair bit more research in order for us to better understand how they work, how they perform, and whether we should move forward to recommendations. Moving on to the next slide, we're really spending a lot of time thinking about what tests to use. There's been a lot of discussion recently around what are the optimal tests in order to try and identify people who are infected, as well as to try and identify those who may or may not have been infected in the past. We currently recommend the use of nucleic acid testing, or otherwise called molecular testing, to identify patients with COVID. There are a number of technologies that now exist. Some of them have US FDA emergency use authorization listing. Some of them have our WHO pre-qualification emergency use listing. And some have the European Union CE mark and other regulatory approvals. We have one set that we consider as automated platforms, and these are effectively, you put a sample in and you get a result out. There are a number of more manual open platforms that allow for more flexibility and fortunately greater access to test reagents. But we really want to think about some of the biosafety standards. We did put out some recommendation a few weeks ago now on relatively tight biosafety standards, but we will say that we're looking to lighten those biosafety standards to allow for more decentralization of testing, given the importance of being able to get a rapid result, clinically manage a patient if they're needed, but also start contact tracing. And of course, we want to be sure that specimen handling and transport can be considered. Moving to the next slide. Right now, we currently do not recommend the use of antigen detecting rapid tests for patient care. However, we're very interested in their use and really want to look into and understand the research of their performance, as well as any potential diagnostic utility. For one, we're thinking this could be potentially useful in the case of identifying patients who have COVID and thinking about how they could work well with nucleic acid tests, whether they might provide significantly more access to testing for patients, and how we balance that with the potential performance. If you click on, we also currently do not recommend the use of antibody detecting rapid tests for patient care. But again, we're really interested to see how some of the research goes to show us the usefulness in disease surveillance and epidemiological research. A number of countries, partners, et cetera, have really been thinking about how antibody detecting tests could be used. And we have a few concerns, at least at this stage, in terms of whether they should be used for diagnosis. And if you click on, some of these include, number one, whether we don't at this stage know whether antibodies actually confer immunity to another round of infection. We're still not entirely sure what the rates of seroconversion even are. And if used in diagnosis, antibody RDTs are unable to discriminate active from past infection. There's the potential for false negatives. Patients who are early in infection may not yet have antibodies. And in some settings, given that a lot of our country programs have really been developed by TB, malaria, HIV systems, there sometimes can be an over-reliance on the test result. And so we have some concerns that perhaps clinical acumen may not play as strong of a role, particularly if this test requires much more nuanced interpretation. And then finally, some concerns still remain around the performance of these assays. That said, we're very much looking into these and really trying to work with a number of key partners to better understand their utility. Moving on to the next slide. Because of the limited access to diagnostics thus far in most low and middle income countries, the WHO with some key partners have developed the Diagnostics Consortium for COVID-19. There are a number of assays that currently exist that have already been placed in most countries or a lot of countries for HIV and TB programs, and that includes those from Abbott, Cepheid, and Roche. And this diagnostic consortium is bringing together some key procurement agencies, key technical partners to, number one, try and gather as much information and data on tests and development that we can. We're then working with suppliers to negotiate access to tests as well as lower the prices. Once we have a pool of tests, we're looking to develop an equitable allocation for distribution of those tests to low and middle income countries, given that right now the need is quite dramatically geographically spread across the world. And then of course, thinking about the additional technologies like those I just touched on to be brought into the consortium to be able to provide access to those markets that may not always get access to testing. But that said, I think we also want to encourage that countries consider a multi-pronged testing approach. In the times of COVID, this may require consideration of both automated and manual assays, and perhaps multiple versions within those in order to meet the testing demands. And going on to the final slide then, when some of the key considerations in particular that we've been thinking about now with my HIV hat on is with HIV and TB. Like I said, a number of the COVID diagnostic tests that do exist have already been, or can be used, have already been placed by HIV and TB programs. And at WHO, we do encourage collaboration and sharing of currently existing molecular platforms to support the response. However, we do feel it's essential to maintain some of the critical molecular diagnostics, in particular for early infant diagnosis, given that that population can have significantly high morbidity and mortality. HIV viral load for specific populations, potentially including people living with HIV disease and those suspected of failing treatment. Infants, children, and adolescents also have high rates of drug resistance, and so we want to make sure that we're able to adequately treat them based on the effectiveness of their treatments, and then of course TB patients as well. One other key point, and this should hopefully help as we loosen some of the biosafety standards for COVID testing, is that we don't recommend moving significant numbers of equipment to centralized settings in response of COVID, because we want to ensure that we don't disrupt the current testing networks. So with that, I want to thank IAS for the opportunity to present and hand it back to the moderator.
Thank you very much, Dr. Voshnov. There is a lot of questions all around the world on the different testing modalities for COVID-19, and I'm sure the questions will keep coming through the Q&A box in that's provided in Zoom, and so I invite you to stay online because we'll take question and answer at the end of the sessions. Now I will invite Dr. Rachel Besley, who is the team lead for testing, preventions, and populations at the Global HIV, Hepatitis, and STI program at the WHO in Geneva. Her work is supporting a global normative guidance on testing, including HIV self-testing and partner testing services, and considering how this can be implemented strategically, safely, and acceptably for populations. Rachel will speak on strategies for HIV testing and initiation of treatment during the COVID-19 pandemic. Over to you, Rachel.
Thank you very much, Adiba, and good morning, good afternoon, good evening to everybody, and thank you very much, IAS, for this opportunity to participate in this web. Next slide. As our worlds have all been turned upside down by COVID, and health systems and countries are all really and rightly focusing on the response to COVID, it's also incredibly important to continue other health systems and services. I'm particularly focusing here on HIV, because if we don't continue supporting these, the unintended consequence of a response to COVID will be increased mortality and morbidity for many people across many infectious diseases. So WHO, like all organizations working on HIV in low and middle income countries, is really focusing on maintaining supply of antiretroviral therapies to people living with HIV, and working to increase multi-month scripting, ways of delivering drugs safely through pharmacies and community pickups, home delivery, keeping primary healthcare open for emergencies, and using digital platforms to support people on treatment to help them continue. But we also need to try and maintain testing services. We've done fantastically well, really, towards the first 90 of the UN targets, 90% of people with HIV who know their status. But we still have about 8 million people who remain undiagnosed and need to be supported to be diagnosed and linked to treatment. Next slide. So why is it important to continue testing? People who are undiagnosed with HIV need to be supported, be tested and linked to treatment for their own HIV health. But we don't know at this time what are the interactions, if there are interactions between HIV and COVID-19. However, we do want people who have HIV and who are immunocompromised or have comorbidities to be supported to get on treatment. So this may help limit some of the COVID-related complications. When we're delivering testing, the first thing is we must make sure that testing services are provided safely during these times of COVID, and ways of supporting testing outside facilities and supporting people to obtain services through digital and other means should really be prioritized. However, we will need to continue offering testing in clinical services, particularly in antenatal, where testing should be offered to support not only maternal health, but also to prevent transmission to children, and that's HIV and syphilis testing. We also need to continue supporting testing for people with HIV to allow their partners to be tested. And again, here we can think about ways to reduce client-provider contact by self-testing, and I'll come on to that into a moment. Key populations, and in the HIV world, we consider key populations as people, as men who have sex with men, people who use and inject drugs, transgender populations, sex workers, and people in prisons and closed settings. We really need, again, to prioritize HIV and the other services for these populations. We need to keep supporting linkage and referrals to ART, and really forgotten, I think, is continuing to supply condoms and contraception, again, because we don't want to increase the unintended consequences of the response to COVID. Also, special considerations for supply chain management. For example, if we're increasing self-testing, to really think about the procurement issues really at an early stage, because disruptions will occur, because transport is obviously compromised because of the response. Next slide. Here I'm really going to talk about self-testing and realizing the role of self-testing during the time of COVID. WHO has really supported self-testing for a number of years, but we think that it's a real opportunity to expand self-testing use during the time of COVID. Self-testing can be an acceptable alternative to maintain services while adhering to physical distancing. But we must use self-test strategically and support testing in priority areas, priority epidemiological areas of the populations at greater need. And for countries that already have self-testing programs, really an opportunity to replace facility-based testing with self-testing where possible to help decongest health facilities. And in countries that are not yet using self-testing, I think this is a real opportunity to fast track approval of self-testing and get self-testing implemented in programs. Next slide. I think, you know, here we are in the end of April, and I think, you know, we've been living with COVID now for 4 months, and it's absolutely extraordinary how it really has turned our worlds on their heads. Yet, I am continually amazed how countries are responding to adapt their services to try and maintain HIV services during this time. And I'm just going to give you a couple of examples which were shared with me by Kim Green from PATH, one here from Vietnam, where they have adapted their service to an entirely safe HIV testing services through an online reach to people at risk, where they can order self-tests. Self-tests can then be delivered to their homes or from a pickup place, and then they can be supported to test and followed up. And all along this pathway, they can be linked directly to counsellors and providers to support them through the process. Next slide. And very similarly from Ukraine. As I say, I could have given you 50 slides on the wonderful examples that are coming from countries, but again, this is from Ukraine. Again, an entirely of testing and support through the process, through online with oral testing supplies. Next slide. And then I want to look at the other side of the coin. How can we use opportunities that are arising through the COVID response for increasing self-testing for populations who could benefit? And I want to highlight here what's happening in South Africa. It's really astonishing. 28,000 healthcare workers have been trained, community healthcare workers have been trained to support the COVID response, and they're going door to door, screening and supporting testing for people in the communities. But they're not just thinking about COVID, they're thinking about HIV and tuberculosis in these settings, because both HIV and tuberculosis are very prevalent in South African communities. So they're using these community healthcare workers to deliver COVID information, COVID support, but also to check in that people who are on treatment for HIV or TB can have their supplies, and they're providing information about that. Other examples are where the COVID response team is also providing medications to patients. And I would also argue that it's also potentially a way that you could also deliver self-test kits, because wherever we are in high HIV burden settings, men with HIV represent a large proportion of the undiagnosed. And now that many are at home, this may be a good way to support testing for populations that that haven't tested. COVID-19 has and will continue to change many aspects of healthcare delivery. I think one of the potentially optimistic outcomes of the COVID response would be that some of this learning and approaches may endure in the long term, and we may have a much better community and people-centered approach to healthcare using community options and self-care options. My final two slides are just, if you can move on, are resources that we have. Because of the limited time, I put up the links here. All our HIV testing information is available on an app. You can download it at WHO HTS info. And finally, I've provided, and I think you all will have access to these slides. These are all the links of all the information that we have on HIV self-testing. Thank you very much. Over to Adiba.
Thank you very much, Rachel. Just as an example of how COVID has turned the world upside down, we were actually here in Malaysia about to finalize the launch of HIV self-testing, but everything has now been put on hold because we're all under lockdown, and many of us working on the HIV self-testing in Malaysia are also HIV clinicians and public health people. So just an example of how health other than COVID is not getting the same attention as it used to, including HIV. Hopefully it's all temporary as we get a better hold of the whole COVID situation. Our next speaker is Dr. Cassandra Kelly-Serino from FIND. Dr. Kelly-Serino has been with FIND since May 2017 and is currently the Director of Emerging Threats. She has over 20 years of experience working in Canada and US public health and private sector settings. She began her career at the Canadian National Microbiology Laboratory, working on emerging infectious diseases, including bacteria, viruses, and prions. Dr. Kelly-Serino.
Hi, everyone. Thank you so much for the invitation to present today, and good morning, good evening, good afternoon to everybody on the call. The two previous presenters, Rachel and Lara, have done a fabulous job of really positioning, I think, some of the challenges that we're seeing and the need for more information around how to use diagnostics. At FIND, we're very specifically focused on a couple of different things to support gathering that data. Right now, we are working on the rapid evaluation of over 50 diagnostics, and this is through an independent evaluation through a network of 20 collaborating laboratories. And we're focusing primarily on the availability of commercially available diagnostics in the outset, but we do anticipate bringing in evaluations of new diagnostics as they become available and they come through the development pipeline. Just to give you a very quick overview of the work, we have prioritized 21 manual molecular assays. So the manual assays are the nucleic acid tests that Lara had mentioned at the beginning of her talk. 11 of those, we have data already available publicly on our website. So we are doing this independently, and we are making the results of our evaluations publicly available as soon as we have them. And we're sharing those, of course, very closely with the WHO to inform and to be able to guide how the performance of these tests are going to impact which test countries should procure and then implement. All of the tests are not performing equally, so it's extremely important to understand that nucleic acid tests in and of themselves are not all the same, and that the evaluation and the data is obviously critical for understanding how to implement and which test to prioritize. For the RDT, or the rapid diagnostic tests, which we agree and feel very strongly can bring benefit to countries. However, we also feel very strongly that their performance needs to be established so that we understand how to safely implement these tests into any kind of testing algorithm. There are 5 rapid diagnostic tests from 4 different vendors that are currently commercially available in the market, and we are testing those right now. We hope to have that data available to share publicly in the next couple of weeks. And then, as Lara mentioned, the antibody-based tests, whether that be rapid diagnostic tests or ELISAs, we're much more hesitant on, but we do feel that their evaluation of these tests is critical so that we understand the performance. There's a lot of preliminary data out there that shows that they do not perform very well. And if they do perform, it's in very narrow windows of time. So I think speaking to how Lara presented about the use of the tests in combination with molecular and antigen-based testing is absolutely critical. And the only way that we can inform good decision-making on this is with the knowledge about the performance of the tests. So there is over 40 of those tests that we have in the pipeline to evaluate. We're just starting those evaluations now, so it will be a couple of weeks before we have any data to share. Right now, what we're seeing from an innovation side, a lot of the tests that have been developed were developed obviously very rapidly and at the very early days of the outbreak. And so what we're expecting to see is that optimization is going to be needed so that we have better access to reagents that are specific for this circulating strain of coronavirus and not necessarily going to cause overlap with previous strains. And in that pipeline, we do see, I'll speak only about the antigen RDT right now. I think that's the one where there's a lot more attention and a lot more innovation happening. There's over 22 developers that are coming to the market probably in the next 3 months with new tests that hopefully are using better reagents and more specific reagents. So we may actually see an improvement in the performance of the tests that we're currently evaluating. And I think that's everybody's goal, is to be able to ensure that countries have access to well-performing tests. But the other flip side to that is the access side, and that's something that FIND is also actively working on as we talk to the manufacturers, is to understand what is their manufacturing capacity, what is their availability to supply into countries that are not in the highest income bracket, that have the ability to put in these very large orders that we're seeing going in and swamping the markets. And so what we're trying to establish is a range of tests that are well-performing, that have manufacturability and scale, so that, as was mentioned previously, countries then have flexibility and choice in terms of which test to implement. A reliance on a single test is likely going to be a very bad decision, simply because that test supply could dry up quite quickly or unexpectedly. And so having multiple different nucleic acid kit tests that you can actually rely on, and then hopefully as we get there with antigen-based RDTs to supplement that and to bring testing out into the community so that you're not bottlenecking and you're not overwhelming limited laboratory health services in some areas. So I think I'll leave that there for now, and then I can take any questions online as well.
Thank you very much. Thank you very much, Cassandra. We're going to move on to a video presentation that was recorded earlier from Dr. Jerome Kim, who's currently with the International Vaccine Institute in South Korea. For everyone who's been following the COVID pandemic, South Korea has been one of the countries that has done well to contain the spread of the pandemic. And one of the reasons for it is believed to be the widespread testing that South Korea has employed ever since the beginning of the pandemic. So let's listen to the presentation from Dr. Jerome Kim. The recording, I believe, is not as wonderful as it could be, and there may be some areas where we might lose some sound in the video. So we apologize in advance for that.
Good afternoon, everyone, and I really appreciate the opportunity given to me by the International AIDS Society to speak about COVID-19 and the outbreak in Korea. The title being Test, Track, Isolate, and Treat, the End of COVID-19, Round 1 in South Korea. So this is the South Korean model, and I summarized it on the left. I mean, the first and most important thing was preparation. Because of the MERS outbreak, Middle East Respiratory Syndrome coronavirus outbreak in 2015, the Korean government modified its procedures and really actually began a series of tabletop exercises on a periodic basis to prepare for the next outbreak. And in fact, in December, by report, there was a tabletop exercise looking at a Korean couple returning from China with an unknown pneumonia. And that was actually pretty prescient, I think. But that preparation helped them when in January we heard the first announcement of the novel coronavirus outbreak in China. So, as with any kind of government operation, command, control, and communications were critical. And the new Infectious Disease Control Act allowed the Prime Minister to have, once an emergency of a certain level, the highest level, red alert, was declared, then there was a clear line of control from the Prime Minister to the Vice Minister of Health, who was in charge of the Korea CDC, and all the way down to the provinces and the districts within the provinces, where the actual activity had to take place. The decisions were transparent, decisive, and data-driven. The messaging was absolutely clear and consistent, and there were posters and things that appeared in your phone, and the things that were on the countertops of public places and in the subway stations and in the buses about what you had to do in order to protect yourself and protect others, and that was very clear. At the same time, the Korean people, I think, and this was also critically important, the government actually recognized this. They were willing supporters of the policy. So when it came to social distancing, hand hygiene, wearing masks, or cough hygiene, the people really did follow these voluntary restrictions. There were no closures of schools. Schools were actually closed for the winter holiday anyway. Stayed open. All these things were fine that you should not engage in. Work was never closed. So, a third of the institute works from home, where I work at IBI, but other people come in. They can come in late, they can come in early. They just have to be at IBI during critical business hours, which are defined as just a part of the day, so that, if people are present for meetings, that they know when to schedule it. The test, isolate, track, and treat policy was really the centerpiece of what Korea did. And we'll talk a little bit more about that. Then in terms of the preparation for release, no one has a playbook or smart book on this. Do you use the negative slope or deaths or cases? Do you use the R0? Or do you use some other figure? Do you wait until your number of local transmissions is 0 for several days in a row? I mean, how do you do this? And where do you decide to start releasing? In Korea, it would be the removal of some of the high-level advisories that were put on activities at gyms, at schools, at churches, etc. Do you have enough spare hospital capacity to handle a surge in case it happens during the release? Do you have the supplies, personnel, masks, protective equipment, etc.? Do you have people to do the test, isolate, track, and treat? It's going to be important as you're letting go to be able to make sure that outbreaks are controlled. And then do you pilot it, or do you just let it all go at once, or different sections at once? So this goes through the Korean alert system. Alert level 1, 2, 3, and 4. Alert level 1, the government just recognizes that it's there. The first case in Korea brings you to yellow alert. A local transmission puts you at alert level 3, and national transmission puts you at alert level 4. Once you enter alert level 4, it changes where in the government the responsibility lies. It shifts for an infectious disease outbreak from the Minister of Health to the Prime Minister. And you can see how all the different things and timelines relate to the alert levels that were put into place. This is, again, the timeline of the outbreak, looking at the new cases, and then, again, looking at where and when these the different alerts were established. And I think, now we've been under 50 cases for 3.5 or 4 weeks. We've been under 10 cases probably for over a week. And if we look at just the local transmissions, actually we've been in the single digits for 6 days now. And to the point now where there's very little, if any, local transmission of disease. But testing was really important, and it depended on 4 things. First, the availability of kits. I think the second is, I'm calling the use of kits. I mean, everyone is reporting now how many tests the United States has done, or Germany has done, or Spain has done, and that's very important. Ease of access to testing, so to make it convenient for people. And then the final thing is some of the issues. One of the issues in particular that has come up with kits in Korea and will come up or has come up in other places, including China. So figure 1 actually shows President Moon visiting Seegene, one of the companies that, within 2 weeks of the outbreak had and was ready to manufacture RT-PCR kits for diagnosis of COVID-19. I think one of the really critical parts of this was that, the government was ready, these small companies were ready, and they had capacity to manufacture kits, and that was really having the kits, developing the kits quickly, following the WHO blueprint for kits was really critical in having the supplies available when testing was initiated. Figure 2 is actually, and I'm going to see if we can get this to work, but this looks, so if you look at the y-axis, this is the number of lab tests performed of COVID-19 RT-PCR, and on the x-axis you have the total confirmed cases of COVID. So if you did one test and one diagnosis, that would be a line that says number of tests equals number of cases. So that's 1-to-1. What you see in the graph are the lines that reflect 2 cases, or 2 tests for every 1 case, 10 tests for every 1 case, 50 tests for every 1 case, 100 and 200. And so those are the little light gray lines that go upwards. And watch how Korea compares to, say, Great Britain, the United States, Sweden, and Italy. And you can see that now. South Korea is taking off, and all of a sudden it hits the rate of 200 tests for every infection. What you see now is Australia and New Zealand, both of which have appeared to control the disease as well, above between 50 and 100 tests for every known infection COVID positive. And I think one of the interesting things about this graph, and the reason I like it because it makes a point, you can look at Sweden, Italy, the United States, and what you see there is a clustering around 10 tests for every case diagnosed. When you look at the successful countries, South Korea, Australia, New Zealand, you're looking at over 50 to 100 tests per known COVID diagnosis. And it really very cleanly separates. So is additional testing necessary? Perhaps. How much testing is necessary? I think these data are curious and interesting and deserve kind of further discussion. The final point here is figure 4. The doubts cast. So Korea's had now, and that's the article here from the Jungang Daily, which is associated with the New York Times in Korea. There have been over 200 cases of people who were initially negative. So to be released from the hospital after you're COVID positive in Korea, you have to have 2 separate days of negative RT-PCR testing. It's the nasal swab, a pharyngeal swab, and a deep cough. And so all 3 of those have to be negative 2 days in a row. And they've been letting people go and then retesting them. And of course, some of them have come back positive. For those of us who are used to doing RT-PCR and kind of understand that you are looking at a virus with a genome of 30,000 base pairs, and you're looking at primer sets that probably measure something like 100 to 200 base pairs. It could be fragments of DNA. Production of the test kits, which were developed within a week. It could be reinfection. It could be a source that is sequestered away. There's data from Germany that would suggest that after day 10, you can't culture the virus anyway. And in fact, that's what the Korean data is beginning to suggest, that what you're seeing is not a PCR artifact, but the PCR is detecting pieces of virus. It's just not detecting whole virus. And again, we detect it on some days and not on others because we're presumably at near the level of detection for the test, the RT-PCR test. For Korea, the use of information technology was very important, and these are screenshots from my phone. The government provided free apps. These are actually some apps that you can download. Emergency alert texts were sent, and actually we've gotten 3 today, including one that notified us that there has been a new infection in our neighborhood in a person who had returned from overseas. And if you click on the link, they've been under quarantine, so there's nothing to worry about it. But on occasion in the past, we would have so-and-so returned from the United States, was tested positive and had been seen at the following marketplace. and was there from 10 o'clock in the morning until 10:15 in the morning, picked up red peppers and left, and was verified by CCTV footage. So if you were there between 10 and 10:15 and you develop any symptoms or, that are suggestive, let your healthcare provider know, because you can be tested free of charge. And that's the way the apps work. They help you to analyze and potentially reduce your own risk, to seek appropriate testing. And if you test positive, then the government will put you into under observation. What's shown in the Corona map is actually something where you see the little orange colored circle. If you tap on that, it will break down into your district. So the map gets bigger and bigger until our district, Sodemungu. I can see where all the infections occurred. And the green dot indicates that it's 4 days or more since the actual diagnosis was made. If it's yellow, it was diagnosed yesterday or today. So you can tell exactly where the people were at any time relative to where you were. And it's all present on this little phone app. It's completely anonymous. You don't know who it was. They just tell you there was a case here. Click, go to your local district office website, and you can get more information on where that person was and who they might potentially have exposed. Other government measures included things like finally, setting up a thing where people coming from Europe, the United States, had mandatory testing on arrival, to now where people from the United States have 14 days in quarantine, and Europe, 14 days of quarantine, self-imposed if you are okay with it, but mandatory if they catch you violating quarantine. This is a self-quarantine safety app. It monitors your symptoms and location. In fact, when you come in and you have this little app, it asks you questions about your symptoms every day for 14 days. And at the end of 14 days, it says, okay, you're fine. If you have any problems, call the following number, but bye. And that's it. It goes away. If you happen not to answer the symptom guide, or if your GPS signal happens to fall off the map, the government officer responsible for checking on you will call you. And if you're not answering, then we'll come to your house and talk to you, because they really want people to take appropriate measures to protect themselves and others. So the out-of-bounds alert, the symptomatic subject alert. And this is where, it's not only testing, but tracking was really important. So there was an outbreak in a call-in center, so an insurance company's call-in center in Seoul. And the Ministry of Health and Welfare, the KCDC, did an investigation. The index case was sitting in the in the part of the floor where all the blue and white symbols are. Those are the chairs of the call-in center. And the index case was one of the members in the call-in center. And you can see 79 people sitting in that room got infected. A total of 94 on the same floor were infected. But very few people who were not on that floor. And so presumably had been exposed in elevators or by contact. But this allowed the ministry then to track all these people, to find their contacts and to isolate them, to test them, and limit the outbreak to the people who were exposed and then the people they may have exposed. So again, this system prevents, accidental, one of these people, the family of one of these people going off to a theater or going out to a bar and infecting other people. So again, it's not only testing, but having tracking systems in place that were really critical. And then, you can see the, the importance of proximity, or either duration or intensity of exposure with this test and track map. And what's left are the backup slides, and you're welcome to look at those and keep those. Thank you.
Okay, as you can see, South Korea has an amazing system in place to test, isolate and track. And I guess from what you just saw, it's no surprise that they have been very successful in containing an initial outbreak that was pretty large. And with that system in place, they have really been one of the success stories in the East. Dr. Kim, as you know, is not online with us. So we'll move on to Dr. Benson Yeo from Singapore. Singapore was able to contain COVID-19 like many countries in Southeast Asia initially, but unfortunately in recent weeks have had outbreaks amongst the foreign workers. So Benson, if you can share Singapore experience with us. Thank you.
Thank you, Prof. Adiba. Good day to everyone. I'm Benson Yeo from Department of STI Clinic, Singapore. Thank you, IAS, for the invitation. I'm going to actually talk about impact of COVID-19 on HIV testing trends in Singapore. Next slide, please. Right. So some brief background on how we do HIV testing here. HIV testing in Singapore requires names of all patients with a positive result to be reported to the government. And asymptomatic HIV screening is carried out by many primary healthcare providers. And the largest numbers are done by the Department of STI Control Clinic or DSC Clinic. And we are also tasked with carrying out the National STI Control Program. However, there are 10 sites in Singapore which are exempted from the above rule and can carry out anonymous testing. And the largest operator would be the Action for AIDS Singapore via our anonymous test sites and mobile test sites which are done on buses. Right, next slide, please. Right, so this is what happened for restrictions of movement within Singapore, and later I'll explain how it affects testing both in DSC clinic and in our anonymous test sites. So from the 7th of February, Singapore has been DORSCON orange. That is our second highest alert level in our disease outbreak response system condition. This is where companies start their business continuity plan with team segregation implemented across institutions. We also started our travel restrictions, temperature screening, and deferring of large-scale events. Finally, from 7th of April, when our second wave of COVID-19 hits us and we had the outbreak, especially within our foreign workers dormitory, Singapore implemented a circuit breaker measures. This is when only essential services are allowed to be open. All other services are closed. So only healthcare, food services, and supermarkets can be open mainly. Everybody must wear masks when they're outside of their home, and social distancing of 1 meter apart is mandatory. Otherwise, we'll be fine. And everybody is encouraged to stay home except when we run essential errands and for exercise, actually. Right, so next slide, please. So this is what happened at our anonymous test sites, the number of HIV tests. From January, when we are having news of the novel coronavirus outbreak in China, it has already started dropping the number of tests done at ATS from 570 at the same month the previous year to 422. And once there was a DORSCON orange announced in February, there was a sharp drop of 70% tests done. That was when most of our locals here were slightly alarmed, or actually very alarmed by the DORSCON orange announcement. And then in March, where there seems to be some respite with initial decline in COVID numbers, COVID-19 infection rates in Singapore, people started coming back to ATS for testing, and they only had about a 48% decline in the number of tests in March, from 544 the previous year to 283 in March this year. Finally, in April or this month, where we had very large, high numbers of COVID-19 in a foreign worker dormitory, and with circuit breaker measures implemented, resulting in reduced capacity limit on the number of staff numbers and pre-registration required, including collection of numbers. So they are no longer that anonymous, resulted in a very large decrease in the number of people coming forward to our ATS sites to test. So from the same month in 2019, where we have 428 tests done for HIV, for this month we only had 127 so far, or 70% decrease. So next slide, please. Right, so at where I work, the Department of STI Control Clinic, we also started seeing decline in January, just because people are coming out less to test. So there was a 21% decrease. And in February, when we started our DOSCON Orange, there was a 25% decrease in number of HIV tests compared to the same month last year. And then finally, when we reached April with a start of circuit breaker measures, we were actually actively deferring patients coming for asymptomatic screening, and we just continue management of symptomatic sexually transmitted infections, and at the same time testing these patients for HIV, resulting in a 45% decrease in HIV tests done in our clinic itself in the month of April in 2020 compared to April in 2019. Right, next slide. Thank you. So moving forward, testing services operators like us, I think we have to remain nimble to respond to various scenarios that may develop. Like in Malaysia, we're actually planning to have a pilot trial of HIV self-testing this year, which is now shelved for the time being. At the same time, we need to engage authorities on the need to continue HIV screening, that this is an essential service that we have to continue providing in the event that there's a protracted lockdown or in this case, a circuit breaker measures. And we will have to ensure there's robust infection control measures by us, the testing service providers, in place for both our clients, patients, and staff protection, and also to reassure the authorities that there won't be a cluster happening just because we are going to carry on testing services. And finally, we should continue to reach out to clients on the changes of workflow when they come and see us for testing, as well as continue our outreach programs digitally so that people are still reminded of the importance of safe sex and the importance of HIV testing. Right, I think that's my last slide. Thank you.
So thank you very much, Benson, for sharing with us your experience in adjusting your services for HIV testing in the setting of the circuit breaker, or as it's called in Singapore, or lockdown in other places. We have about 20 minutes or so for Q&A. Right now, my screen says there are 486 participants in this webinar. And many of you, thank you very much, have posted questions to the Q&A box. And our panelists have been very diligent in answering many of them. You now have an opportunity to ask your questions of the panelists, and please let us know who you want to direct the questions to. Of course, Dr. Jerome Kim is not with us. It's unfortunate because he just shared a very impressive model of the pandemic response in South Korea, specifically on their testing strategy. So I open the floor to questions.
Great. Hi, Deepa and Anil. Let me step in here because people have been sharing questions through the chat. And I think just in the interest of time and the connection around the world, it's probably easier to respond to those questions and direct them to some of the different panelists. So maybe actually, if I can ask, this one is actually directly to Rachel. The question that's come in about if the WHO has published any guidance for settings that cannot do regular viral load testing due to COVID-19, and how to determine if a patient is stable at the moment and accessing ARVs, or what other guidance could there be in terms of defining a status as stable during this time?
So, and I'll also bring in Lara here. We haven't at this moment, as far as I'm aware, we're in the process of, as you can imagine, as everyone in WHO is trying to adjust all our guidance to the time of COVID. at the moment, we haven't adjusted our viral load guidance, other than doing as Lara says, to prioritize viral load for people who are symptomatic with HIV, or who have a history of of increased viral load, so or advanced disease. So people who, I think it's more a matter of being really pragmatic. So people who are already stable and have been stable for a period of time, those would be the ones who would be in this. You know, it's hopefully not going to be for an enormously long period of time, but to be supported to have multi-month scripting without the need for a clinic visit. I mean, this has been our recommendation for some time, even before COVID came, that we wanted to make access to ART much simpler for stable patients. And there are already, I mean, a large percentage of people who are on treatment are stable, and really it's to support that continuation. But at the same time, and as I say, this really applies across the board to all chronic conditions. There will be a need for patients who have complications, who have symptoms, who have new symptoms, to see clinical care. And that's why we need to keep those platforms for viral load still open to support clinical management. Don't know if Lara wants to add anything.
I'm sure. Yeah, I think I would agree that at this point, we're not suggesting to stop HIV viral load testing, as well as, tuberculosis testing, or in particular, also early infant diagnosis. I think there are some critical populations, particularly, that do still need some viral load testing. And so ideally, those would continue to get care. But for those patients who have been on ART, who seem to be stable and healthy, are taking their treatment, perhaps, as Rachel is suggesting, they're able to get a little bit more of multi-month scripting, and not come in and get as many touch points with the healthcare facility. But I think we'd still, in the absence of viral load testing for some, would then, suggest that we go back to some of the clinical signs and symptoms of potential treatment failure as well. But hopefully the systems that have been created to support both HIV and TB testing are maintained in order to continue those critical diagnostics for populations.
Great. Thank you, Rachel. Thank you, Lara. A slightly different question, but still in relation to HIV testing, and specifically HIV self-testing. So maybe I'll direct this to Dr. Benson in Singapore, but also back to you, Rachel, as well. The question is that if people are still having issues of stigma and have a fear of testing, how can we encourage HIV testing, including self-testing and the return kits during this time?
So the question is, how do we encourage people to do self-testing?
Yes, in prevailing issues around stigma and other barriers for people to want to take a test.
Right. I would think self-testing would be a good way for people to avoid feeling the stigma of coming to a test site that is specifically to do to test HIV. But the problem is HIV self-testing is not approved yet, at least in Singapore, and which is what we wanted to do as a trial this year, but that would have to be postponed for now. I think management of stigma it's difficult, and there are legal barriers to that, which I think many of us are trying to overcome in Singapore now.
Just to add to that, what we've been working on self-testing at WHO for a number of years, and what we found is that it's extraordinarily empowering ways to learn your status. And as I say, I would urge anyone who's interested in this to look at some of the material, the links that I've done, including some of the videos that we have with people who self-test. To go to a clinic with that knowledge that you've tested and you have HIV puts you into a really good position to discuss with your healthcare provider. You don't have to start off by being quizzed about why you want to test and blah, 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 and discussing all your potential risk factors and etc. You can start by saying, I've had a test. It's come up positive. Please can you help me to get that confirmed and support me for treatment. So it's we have numerous projects amongst people from key populations in many parts of the world where HIV remains very stigmatized, but yet this approach really seems to have supported testing where people haven't been felt comfortable going initially to facilities. So, and my plea to Singapore and to Malaysia is, this is the time. People are making really rapid decisions in all the COVID implementations. This is a response that we could really support self-testing in this time, and let's lobby for fast tracking it.
Thanks, Rachel. And actually, Adiba, I was going to be a bit cheeky and come to you as well from your experience in Malaysia during this time, and any creative ideas you've had to respond to issues and encourage, issues of stigma, and encourage people still to test for HIV during this time.
I think one of the, not so much in the realm of testing, but in terms of interruptions to routine care. I mean, I work in a very large tertiary care hospital that had to reorganize our services to provide for COVID management. And one of the things that we had to do was to limit the number of people attending outpatients clinic, although we didn't close the clinics, but we had to limit the number of people coming at quite a short notice. So, and to ensure that there was no treatment interruption. So there was quite a lot of work involving, contacting patients, making sure that they had their medicines delivered during the lockdown phase in Malaysia, and so forth and so forth. So yeah, testing, apart from stalling what was a very close to launch of the HIV self-testing. So Rachel, I take up your challenge and see if we can fast track that. We also had to make sure that routine HIV services were not interrupted, and treatment was not interrupted during this period.
Thanks, Adiba. And a question that's come in, or comments that's come in on the YouTube channel, is actually in relation to stigma and the response and the association with COVID-19 as well, and a comment where a family has been experienced violence based on the positive diagnosis for COVID-19 in that community. And it's unfortunate that Dr. Jerome Kim couldn't be with us live, because I'm sure he'd have some interesting reflections from that case he concluded with about the index patient and that call-in center.
Well, so if I could share my experience there, Lucy, because in fact, we were just discussing this this evening. We had a healthcare worker who was infected with COVID in the community, and subsequently, came to work not knowing that she was positive, and resulted in a few other healthcare workers and patients being infected. Now, she's facing a lot of stigma, both in the community and unfortunately, within the healthcare setting as well. And it's pretty reminiscent to, the early years and the current stigma that people living with HIV experience. But it is very real. She is almost having a PTSD kind of reaction, and we're needing, where we are providing sort of mental health support for her. So it's, and you hear of these incidents more and more. Yeah.
Thanks, Adiba. Thank you. Now, if I can shift to some of the questions that are coming in, more specifically around testing for COVID-19. This is both a technical question. This is for Cassandra, Dr. Cassandra from FINES, a technical question, but also a broader policy type question for you. The technical question is, which performance criteria will be used for the selection of best performing assays of FINES evaluations? And then the more policy type questions is, what considerations would you advise people for the rollout of mass testing in low or resource limited settings for COVID-19?
Yeah, thanks. So the performance, it's not based on performance criteria. We had a selection of different criteria that we're using to look at the over 400 applications that we had to our independent evaluation for the diagnostics. So on our website, and I did post it in the response to the comment, you can actually see the criteria that we used, and as well as the resulting data as it's rolling off. We looked predominantly across the claimed performance. Amazingly, some manufacturers actually submitted their tests to be evaluated with extremely poor performance data, so we felt that we likely weren't going to prioritize those. But then much more than that, we really wanted to look at the ability of good quality manufacturing. We wanted to make sure that these manufacturers have footprint or existing supply and delivery chains into low middle income countries. And for the molecular assays in particular, we wanted to make sure that they were using platforms that were going to be readily available in low middle income countries. So we deprioritized ones that would only be most applicable, let's say, to the US setting, or very high income setting. And the other factor was in speaking with the companies themselves, we did have conversations with the ones that we had down selected, was around whether or not they had ability to manufacture at scale. Some of the ones that have applied are really just only able to produce 100 or so tests a month. It's just not going to really meet any kind of demand. And so we wanted to prioritize those that would actually have the ability to meet global demand and scale. But again, going back to what I said in my presentation, which is that we recognize that global demand and supply is not going to be met by one manufacturer. There has to be many manufacturers that are performing well and that we're able to tap into in order to make sure that all countries have access to tests. From the policy side, FINES doesn't do policy, so I would hope that somebody, Lara maybe, or somebody from WHO would step in here, but for our intents and purposes, the way that we're going to share the data is openly on our website and in a performance, and we're also looking at not just the sensitivity and specificity performance of the assays, but definitely in terms of what type of sample. So when during the course of infection do these tests work? That's especially important for anything to do with an antibody-based test, because it's not going to work across the entire spectrum of the infection. And we're also looking at the ease of use and the ability to implement these into health systems that perhaps can't take on very complex tests, or in community, more decentralized testing schemes. So that's another ranking factor in terms of the way that the data will be presented.
Great, thanks, Cassandra. And actually, Lara, if I could pass to you, but with also a follow-up policy type question. It refers to, at the end of Dr. Kim's presentation, he summarized some impressive measures taken in South Korea to curtail the spread of COVID-19. And are these measures, or could you advise on some of those measures that could be replicable in other parts of the world, particularly in resource limited settings?
I can do my best, but I think for the most part, what the experience in Korea is certainly one that we are looking at quite a bit to understand, whether it's repeatable in other countries, as well as, what are the best practices in doing so, and how we can make some of those policy adaptations. And of course, looking at the research that's being done across the space on the diagnostics, but also on clinical management. We have quite a large clinical management team here who's really looking into this. And so, you know, we're having regular conversations every day, really thinking about what new is coming up, how we can really quickly adjust any policy decisions, update any policy decisions and bring in new ones based on some of the experiences of countries across the board. So it's definitely a dynamic situation, and one in which we're trying to gather as much as we can in order to support countries in terms of how they adapt some of those different strategies across their own settings.
If I can chime in there a little bit about whether the measures taken in South Korea is replicable, because here in Malaysia, as we try to exit the lockdown, different groups are looking at how to do this best and safely. And of course, in this region, South Korea has been one of the countries you look to. What was described there, I think, apart from the massive testing rates around the country, I think the other impressive measure was the wide use of technology. And what they did to really pinpoint where people were was to use you know, a triangulation of credit card and telco data, et cetera, that I think in some countries, individuals might find a little intrusive. So it's, I think those debates are ongoing in many countries. The technology is definitely there. Some countries use Bluetooth capabilities to track where people, you know, the movements of individuals, and in South Korea it's telco and credit cards and other kinds of data. And the question is, will individuals in advanced countries accept these kinds of monitoring?
Thanks, Adiba. It's interesting to hear about those experiences as well, and questions around, I guess, surveillance and security and privacy and things are all being raised, linked to important, you know, tracing actually people's movements and things. Thank you. A question here, actually, probably back to you, Lara, and also potentially Adiba from your perspective from the medical school. But a couple of questions have come in relation to any protocol or guidance related to testing and approach to diagnosing COVID-19 amongst healthcare workers. Is there any data in terms of monitoring how many healthcare workers have been affected, but also do we know what has worked best in terms of best supporting and protecting the healthcare workforce from the pandemic?
Yeah, I think one of the most striking thing about the COVID pandemic is the number of healthcare workers who've lost their lives in many countries. So certainly at my own institution, this has been foremost in the design of our response, because we as I said, we're a large tertiary hospital, and we're a hybrid hospital. We couldn't afford to be a solely COVID hospital, so we also had to manage other patients, and on top of that, our hospital is right smack where the epicenter of the infections in Malaysia and Kuala Lumpur is at the moment. So very early on, we instituted a risk assessment and healthcare workers surveillance system within the hospital, learning from that very early experience of having a positive healthcare worker who didn't know that she was infected and then went on to infect a few other healthcare workers and patients. So we quickly put in a surveillance system, and to date, we've had, I think, about 1,600 healthcare workers under surveillance, and each one of them is risk assessed, and depending on their risk, are told to self-quarantine for 14 or 7 or 3 days.
out of all those whom we have under surveillance, very few have been, some have been infected in the community, some through healthcare worker to healthcare worker transmission, but very few were infected directly from patients. And of those, it's from breach of PPE. So what we found was that those working in the COVID wards had zero transmission. And that's, I think, thanks to awareness, but also to adherence to wearing the right PPE for the right procedures.
Great, thanks, Adiba. Very interesting to hear about that example. Lara, from WHO's perspective, anything to add more generally considerations there?
Just to say, that we have a couple of guidance documents. They're maybe not as elaborate or really discussing some of the operational protocols and guidance, but we definitely do consider healthcare workers within sort of the high-risk population that, should be prioritized for testing with limited resources. Of course, ideally we'll test, as the Director General says, but that is certainly a key population for us. And one in which I would encourage looking into some of the additional guidance and that comes out and that has been published already on sort of how to support that a little bit more.
Great, thank you. And one final question for Dr. Benson in Singapore and also Rachel from WHO. Questions come in relation to health inequities and what we can see both in terms of learning about access to testing in relation to HIV and the health inequities in which we know historically HIV has thrived in terms of transmission, and any learning we can apply to that in terms of targeted testing and outreach specifically for marginalized communities to promote access and enable access to COVID-19 testing as well. So perhaps from the Singapore experience first, and then in conclusion to WHO for that question.
Right, so in Singapore, our tests are not that expensive, so it isn't really a financial restriction on doing the test. It can be about $10 Singapore dollars to $50 Singapore dollars, depending on where the test is done. But the problem we do face is we are not able to reach some of our hidden population, which is our usually our slightly older men who may visit commercial sex workers. So somehow our outreach programs, our platforms that we do our outreach on have not reached them, and they are still the people that present late with HIV as opposed to men who have sex with men, maybe who usually gets diagnosed earlier and in asymptomatic stage, and we do all know that it's a much better prognosis in people who are diagnosed earlier. So in terms of equity, I think that's the problem we face. How do we reach them, and how do we remove the stigma of them feeling that they don't need to test, or they will feel embarrassed to come and test?
Thank you. Rachel?
Yes, well, this is obviously an extraordinarily difficult question. And COVID, as with so many other things, HIV, TB, non-communicable diseases, health inequities are extraordinarily stark, and the response in low and middle income countries to COVID will face those challenges that we face across the board with health, with all health issues. I don't have an easy answer. All I can say is, countries, low and middle income countries are finding solutions and in responding in incredibly innovative ways, and are prioritizing this in a very, very impressive manner. And as I gave the example from South Africa, which has put enormous amount of human resources into this, I think, but as we move along learning all the time, I think it is really important to think about how we can make sure, and as Laura said, make sure that we can work together to get the best price for COVID testing for low and middle income countries, but also we can address the other social consequences that are going to be devastating, access to food and all the economic hardships. So it's a really collective global response that's needed. And, we have really hopeful learning from HIV. I mean, no one thought when 3x5 was launched that we would now be where we are with HIV, with, the vast majority of people with HIV in Africa now being on treatment. But it's going to, as I say, require us all to work together and to really prioritize low and middle income countries in our response.
Thanks, Rachel. And I think also in thinking about the question is also that certain communities within countries as well who face extra barriers to accessing services.
Absolutely. And, I think people who are homeless, I mean, we've seen, every single country, people who are at unemployed and homeless, people with other, facing legal barriers, people who are migrants. So again, it's being flexible and trying to have a response that supports everybody in the community and is supporting those needs, holistically with the food and the shelter, as well as the COVID response.
Great. Well, we're almost out of time, so I'd really like to thank the panelists very much for your time today, and thank you to Adiba for moderating such a fantastic session. I'd like to encourage everyone to please do look at the IAS website for access to this recording from a webinar will be uploaded within the next day or two, and also for slides from the presentations. And please do send any ongoing questions by email to coronaquestions@iasociety.org. And thanks once again to the speakers and to Dr. Jerome Kim for the pre-recording, for remaining with us also for the questions. It's been a very rich discussion. And we really appreciate your time. It's very busy and pressing for everyone, especially for you who are so involved in the response directly. So thank you very much for being with us today. We'd also like to thank the Swiss Agency for Development and Cooperation and Merck Sharp and Dom, our donors, without whom this webinar series would not be possible. And we'd also just like to let everybody know that on conclusion of the webinar in a moment, you'll be directed to an evaluation survey to share your feedback. It's a short survey and we really value your thoughts as to how we can improve these series going forward. So please do take a moment to complete that survey. Thank you very much for your time, and please stay tuned for the next webinar, which will be in early May on innovation as the next one in this series on COVID-19 and HIV. Thanks very much.